Good afternoon. It is distinct honor and great privilege to introduce our speaker today, Professor Abdullah AlFawaz, who is Professor and Chairman of the Department of Ophthalmology at King Saud University. His topic is strategies in managing microbial keratitis. As a medical scientist, Dr. AlFawaz is going to dispel the mystery of microbial keratitis and attempt at finding new ways to approach and diagnose patients with microbial keratitis. It's indeed an honor to have somebody, a great clinician like Dr. Fawaz, who will give us an insight on the managing of microbial keratitis. Dr. Fawaz.
Thank you, Prof. Khalid. Assalamu alaikum and good afternoon, ladies and gentlemen. And welcome for this grand round and happy Eid to all of you. And it is a time that to congratulate people at KKH for the new auditorium. يمكن هذا أول grand round بالنسبة لي to attend in this auditorium. I'd like also to thank them for the continuity of this scientific activity all over the years. ويعطيهم الصحة والعافية. My topic will be in managing microbial keratitis, mostly the corneal ulcer. And in this 1 hour or so, I will run you through a clinical, mostly background and practice about managing microbial keratitis and corneal ulcers. The outlines will touch upon some statistics and introduction about microbial keratitis, various types of microbes that we encounter in treating those patients, the clinical presentation, choices of antibiotics, and some dilemma in managing those patients and challenges that may face us as a treating physician for those patients. And hopefully I can end up with the guidelines and clinical tips that would help managing and giving the best outcome to our patient. As you know, the microbial keratitis is a common finding that you will face in the emergency, and in any general ophthalmology clinic you may face different stages or categories of microbial keratitis, either bacterial or fungal or a virus or other parasitic infection. This variability in presentation and causative and also factors of the patient giving us a variability in the management and variability in the outcome. This is why we lack some of the standardization in some aspect of management, and here the sometimes experience and open discussion like what we are having at the end, inshallah, of the lecture will aid in our knowledge about helping those patients. There are multiple factors affecting the outcome. The patient factor, talking about the age, the location, the ocular disease, the immunity status of the patient also will influence the outcome. The causative organism, either bacterial or fungal or viruses or uncommon atypical organisms also may differ or have different course of a disease. Intervention, either delayed or wrong intervention, may cause a problem rather than help for the patient. And this is, again, we will have some take-home messages at the end of the lecture to help to improve our outcome. As a general rule, we usually ask to know about the pathogenesis of any certain disease, and complete understanding of pathogenesis and the way of the patient behave to the certain stimuli and the way of the microbes behaving in the cornea is important to know how to kill, and how first to know how to diagnose and then how to kill and get rid of the microbes. So over the years, I had a concept that I usually follow. I don't think it is well written or supported by evidence, but in my practice I find it very helpful, and the people who is rotating with me, either colleagues, residents or fellows, we found it helpful, especially in difficult cases. And in this category of patient, we usually try to see the patient in which stage. Is he in the infectious stage, or in the inflammatory stage, or at the healing stage? The problem with this, there is no clear demarcation line in between these stages. It is having different behavior upon. But if you succeed in knowing where is the patient locating in this stage, that will make you more focusing in which treating strategy, and you will sort of expect the prognosis and the outcome. And we will talk about this in depth. If we are talking about the infectious stage, here usually the patient will present with the classic painful red eye, reduction of vision, and the active infiltrate, as we usually describe, is creamy yellowish, thickened cornea like edema, CED, ciliary injection, and in some occasion you will have hypopyon, and the having some picture of the infiltrate may guide you to a certain diagnosis, but again, the standard is to have tissue or culture staining and cultural sensitivity. So what is our aim in this infectious stage? Is to get rid of the organism, regardless of the potential outcome. Here I will not think about the visual acuity. I will not think about high IOP if there is high IOP. I will not think about the extent of the scar that I may have. My aim and my target to get this eye sterilized from the corneal infection. So I need to know the causative organism. I need to choose the best antimicrobial medication. It needs to be effective, broad spectrum, and tolerable for the patient, because there is a lot of medication that can be used, but some of them are causing more harm to the patient, and yet it is not efficient. Because you need to look also at the pharmacokinetics of the medication. There is sometimes good antibiotics, but has poor penetration, so it will not help you much, and vice versa. Frequent installation of medication, which one important thing that we look at is the compliance. If you think there is questionable compliance of the patient, here the admission is important. When we are privileged, especially in our institute and maybe in this institute, that you can admit the patient if you think the patient will not give the right medication. Or if you give the patient and you think the patient is doing fine, he will do it at home, and after 1 or 2 days, there is no much improvement, you need to clarify the compliance, because sometimes putting the medication is a burden on the patient, especially if they are elderly. فلذلك close monitoring is very important, either as outpatient, if you can secure a regular follow-up, or admit the patient, especially at this infectious stage. So how would we identify the exact organism? The golden standard we said is the culture and sensitivity. Special culturing, if you are thinking about atypical organism, either fungal or virus or nocardia, microsporidium, you need to look for special staining. PCR will help you, especially in herpetic or viral entities. ConfoScan is another module that can help, especially in acanthamoeba and fungal. You can see the double wall cyst or hyphae in fungal keratitis. And if you are not having any result out of these, tissue biopsy can be considered. And the tissue biopsy, we can talk about it later, but it will be better to have it at the area between an active and inactive area, so you get to the help of the histopathology. And in our institute, we had the great help from the histopathology department, unit in our department. We can identify, and we did identify some patients who were negative in the initial staining. Bacterial keratitis, as we listened to Dr. Abdulrahman Bouchi a while ago in the uveitis sub-speciality lecture, the bacterial keratitis also have the same. It will differ between where you practice and what are the common organisms that you need to look at. The common organism in our area is different than the one in the East Asia and different the one at the North America. So we need to look to our epidemiological study if it is available, or at least our experience. So there are some few papers coming in the literature from our institute. One recent article published by Dr. Clinton and the colleagues found out 64 was culture positive bacterial keratitis, and among them the most common was gram positive. And the gram positive coagulase negative was the most common, and Pseudomonas in the gram negative category was the most common. And they found out the factor associated with poor outcome was diabetes and poor presenting visual acuity and positive culture. In Kekesh study, which was published in 2016, gram positive again was the most common of the bacterial keratitis. And in their paper also they alluded that there is an increased prevalence of oxacillin resistant Staph aureus, and we will talk about this in a minute. And here we are talking about the choice of most appropriate antimicrobial agent. The controversy will be about monotherapy or combination. Myself, I usually go to combination if I have severe keratitis, central more than 4 millimeter, corneal ulcer, thinning with active melting, patient who is immunocompromised, like what we saw in the diabetic patient, I usually go with a combination fortified antibiotics. If there is a small peripheral infiltrate, no harm to start monotherapy, as fluoroquinolones, mostly fourth generation, is a good medication to be started. We talk about admission versus outpatient. Route of administration, mostly we depend on our topical medication, and the reason is obvious. We don't have an immune system to help us in the cornea, whereas in conjunctiva and the lids we may depend on our immune system. But subconjunctival injection is important in some entities. Intrastromal, especially in fungal keratitis, is having a good outcome. Systemic in a fungal and acanthamoeba is important, and also in viral keratitis. Intracameral, and I want to stress on this point, intracameral antibiotics, in my opinion, is not helpful. In fact, it's sometimes harmful to give to the patient, because you will puncture the descemet membrane, which is a strong barrier preventing the organism to penetrate inside the eye. So usually I try to avoid going intracamerally as much as I can, unless the patient is going for therapeutic BKB and maybe at the same time will inject some antibiotics. But intrastromal is, the evidence is supporting it. Subconjunctivally also is a practical thing to give. Choice of topical antibiotics, as we said, the emerging resistance is increasing, and you can see over the years. For instance, this is the first paper is published in 2016, and they found out the fluoroquinolone resistance is uncommon, whereas the papers published in the last 1 year or 2 years and a half found out there is an increasing resistance against fluoroquinolones. And this is why we need to be cautious in giving the patient the treatment, and we don't need to overuse the medication, because at the end, unfortunately, we may end up of having less choices of antibiotics. Unfortunately, for the last couple of years, I don't hear about any newly commercially available antibiotics in the market. And this is alarming. You need to use this medication efficiently and in the appropriate way. In that paper, they found also there was no overall significant broad antibiotic resistant. However, future surveillance is recommended. All organisms tested were sensitive to vancomycin. Again, you will be amazed when you go to the second slide. Here, this is what I'm talking about, the paper published by the same group from King Abdulaziz in 2023. And here is two tables. The above table is talking about the gram positive, and the lower table is talking about gram negative. And they look to the sensitivity, which is usually coming as a report we take to send for our lab. And you can see in the gram positive, vancomycin, I circulated in red, there is some resistant organism, even from the Staph aureus, when we're saying vancomycin is the best treatment for them. The good thing is the levofloxacin, which is the fourth generation fluoroquinolone, is still efficient to treat in those patients. As we know, fluoroquinolone, as we go from the first generation to fourth generation, the coverage of gram positive is improved. Ofloxacin, unfortunately, is having now less effectiveness in this patient. This is about gram positive. Talk about gram negative. Again, levofloxacin was a good medication. A surprise for me, ceftazidime was not a good, it has some resistance in Pseudomonas. I was thinking ceftazidime is the best treatment for Pseudomonas. Unfortunately, now we have some resistant strain. And this is why maybe at the end of the lecture we can discuss how to improve our judgment and use of these medication. So a clinical tip at the end of this stage, we need to see if there is severe cases, deep central infiltrate, more than 4 millimeter. I start fortified Vanco and Sifta. Don't do, I usually tell my treating team, don't do major changes at the same time. If you, for instance, the result come to you from the sensitivity saying that this patient is a gram-positive, good response or sensitive to vancomycin, I usually don't like to pull the ceftazidime immediately. I start lowering the dose of ceftazidime because of the synergistic effect, and after 2 or 3 days I pull it completely. The same thing also, I don't initiate a treatment that or I play a lot with the regimen, and then in the next day I don't know if there is improvement or deterioration, which factor I link it to. So we need to change things in a planned way. Another thing, I usually don't change things over the weekend where the patient will not have the close monitoring, or the patient will be discharged, or there is no facility of B scan, or things deteriorated, they will be stuck. You have the facilities. Serial picture is very helpful, and I will show you maybe at the end of the presentation how the serial picture will help in judging the improvement or deterioration. Okay, let's say that the patient is there is no much of active infection, or mostly you are controlling. I wouldn't say that we are 100% sure the infection is gone, but now you are controlling the infection. There is thing that you need to look at, which is the inflammation. Unfortunately, in the eye, it's a privilege and also a challenge in our practice. Sometimes the inflammation itself will cause more damage than the infection. And the good example of this is the corneal ulcers, the retina diseases. Sometimes you control the medication, but you control the infection, but at the end the patient will end up with no light perception. Or in the corneal status, your patient will be half hand motion or count finger, or will end up with melting. These are an important thing to look at. The controlling inflammation is as important as controlling the infection. As we know, there are multiple stimuli that can happen in the cascade of the patient response, and these need to be looked at. And this may cause the melting and necrosis and the scarring we had at the end of the course. So managing inflammation response shouldn't affect the infection control, and if you are in doubt, you can wait 1 or 2 days. There is no urgency to control the inflammation where you are in doubt about infection. In general guide, gram-positive anti-inflammatory medication can be started after, in gram-positive you can start in 48 hours. In gram-negative, that period will be longer, but you need to be cautious in cases of smothering infection like fungi, acanthamoeba, and nocardia. If you use steroid or anti-inflammatory medication prematurely, you may end up with devastating outcome. So you need to make sure. Sometimes in these patients you will have intact epithelium after 4 or 5 days, and don't perceive this as a control of infection. Sometimes it is still, there are some signs to look at other than the healing of the epithelium. This is a patient, the one in the top, a patient with fungal keratitis. The one at the bottom is acanthamoeba, where you can see a pre-neuritis. So how would you control the inflammation? Reducing the toxic medication is the first step to reduce the inflammation. As we know, most of our medication we're giving are toxic to the corneal surface. So reducing them if they are not needed, shifting the patient from round the clock to while awake is something that will help the patient. Holding or stopping the non-needed medication like atropine, cyclopentolate also will help because it has preservative. This also can help. And then if you still think there is active inflammation, you need to control it more, you have choices to have. Medroxyprogesterone, اللي هو Provera, can be used, and you have patient who is having impending perforation or thin cornea, who are not so confident to start steroid. Provera can give you a couple of days of control of inflammation. Topical steroid, either use weak steroid like FML or Bridfort. I personally start FML for BID, and then I see the patient in the second day. If he is improving or there is no progression, I increase the FML to QID, or if I think there is also good control and I'm not happy with the control of the inflammation, I can start Bridfort, which is a stronger medication. Use of topical steroid is, I know, controversial, and we have discussion at the end of the talk. But one of the landmark study is the Scott, with all the reservation on this study, but we have certain evidence on this. And their consequence report, they found that in the 12-month Scott report, which was published in 2014, results indicate a potential long-term benefit of corticosteroid in non-nocardia ulcers. They classify the patient bacterial keratitis to non-nocardia and nocardia. Non-nocardia, they found it helpful. In other reports and other reviews, they found that topical steroid, and also my personal experience, I think steroid can be used when it used logically and with safety. It can be more helpful. So clinical tips in inflammatory stage: no harm to wait for a few days. If you are still in doubt, you can delay it for 1 or 2 days. First tip to minimize the toxicity, as we said. It is safe to start gradual with the weak topical anti-inflammatory medication. When initiating them, close monitoring is important. Very important is to, when you start this medication, don't discharge the patient immediately, and don't give the patient long follow-up. You need to see the patient 1 day at least. On the second day or the first or second day, you need to see the response. Because sometimes, even if you are most likely the infection is controlled, you may have reactivation of the infection based on the start of the steroid. Okay, let's say now we get rid of the infection, we control the inflammation. In 80% of the time, the healing will follow. The epithelium will close itself, and that's it. But in certain cases, especially in diabetic patient, neurotrophic, the age of the patient, if they have limbal stem deficiency, you will have retarded healing. And in this case, you need to make sure that you are controlling the infection, and you need to control the inflammation. And we said, as we said, the exception of acanthamoeba fungal need to be kept in mind. And here, the modality of healing or promoting healing will come. Starting with the ointment instead of drops can help. Serum BSS also can help in healing. Tarsorrhaphy, stromal puncture, and debridement, and amniotic membrane. All these modality would need to be done at this stage. You cannot do it earlier, because if you do it earlier, you will cause more harm. You will prevent your antibiotics to penetrate well, and you may cause more infection. And then you need to look for long-term visual rehabilitation. Again, most of the study proven that in the first year, you still have good chance to reduce the scar and the sequelae of the corneal scar. After 1 year, unlikely there will be improvement. This piece of information is important if you are planning to do keratoplasty or doing some intervention to improve the visual outcome. You need to delay it for a couple of months until you have complete resolution, because long-term anti-inflammatory medication like steroid or cyclosporin or tacrolimus can improve the visual outcome even weeks after the resolution of the corneal scar. So most of the time, healing will happen spontaneously. Extensive healing response is as bad as poor healing. Again, you don't want this corneal scar to heal with fibrovascular membrane, with the stem cell deficiency. And here, as we said, cyclosporin and tacrolimus will help in minimizing the vascularization. One important tip here is to avoid non-steroidals. In all stages of microbial keratitis, please be away from topical non-steroidals. Non-steroidals will cause more trouble, and the control of the inflammation is minimal. Okay, Now let's talk about, this is mostly a theoretical slides. Let's talk about the practical slides. Let's see in real life, does this work or at least have some merit to you? This is a 23 years old female patient, came with 1 week history, and the patient is a contact lens wearer. Unfortunately, this is another point we usually face in our ER and in other also referring facilities. The patient will be given some combination of treatment. And the most worst thing to give to the patient is the combination of antibiotics and steroid. And the patient was given Maxitrol, which is antibiotics and steroid, and the patient, in fact, get worse. The patient, when she comes, she was having LB fidgin with central infiltrate, and this is her picture. Ring infiltrate, bad hypopion, and from the picture with a contact lens wearer, there was a few things to think. One of them, with this highly virulent, mostly Pseudomonas acanthamiba, is one of the important differential diagnoses. So we started vancomycin and ceftazidime. Again, this is a severe one with a considerable amount of thinning and melting. And the scraping tend to be a gram-positive bacilli. And the patient was admitted, Q1 hour ceftazidime. And you can see in the second day, there is dramatic improvement when you initiate the right treatment. After that, we continue. We are still at the infectious stage. We try to taper the vancomycin, which is, we found that the organism is sensitive to ceftazidime. We start to taper the vancomycin. Again, I don't DC it abruptly because there is some synergistic effect. I found it in combination of antibiotics, which is a well-known thing in general. The patient start to develop improvement. Symptom cliche is better. So we DC the cyclobentolate. Now we look to the inflammation. We start the toxic medication. We taper them. Third day, fourth day, vancomycin continue to be DC'd. Fifth day, she's again improving. Here we added in the fifth or sixth day the FML because it is a gram negative. And here after the sixth day, when we started the FML in the fifth day, you can see there is improvement. Okay, there's still some injection. So we increase the FML to QID. We DC the vancomycin completely. Patient vision improved to hand motion. And you can see the eye now. Now we are at the control of the infection mostly. There is no, even that area, there can be a questionable activity at the sixth and fifth day. Now it is almost disappearing. It is whitening. There is no more so hypopion. The eye is less injected. Now the healing, we start erythromycin HS. That will be an ointment to help in lubrication as well. And we continue in our ceftazidime and reduce it to Q4 hours, QID, and we discharge the patient in the 13th day. There is still CED, but in the 20th day, there is complete healing. And this is 1 month with residual corneal scarring. 2 months, there is improvement of the visual acuity to 20/80. We saw her before like a couple of months, and she reached to 20/60 almost. This is the patient after 2 months. So if we want to apply our strategies based on and here we're saying the series of the pictures is the infectious stage, the inflammatory stage in between. Here you can see the inflammation is controlled here after we initiate the steroid, and here is the healing. Let's see another picture or another patient. If we have time to see some of the, I think we still have time. This is a 73 years old lady, elderly, and the patient was having comorbidity. Unfortunately, this patient has a phaco procedure which was uneventful, done before 1 year, and the suture was left there. And here would be a point of discussion. Should we remove the suture, keep the suture of BKB, or keep the suture after phaco? Why you should remove it? In general, this is my personal opinion. This is a foreign body and need to be removed. Any foreign body in the cornea need to be removed. You don't know, it is like a bomb that you don't know when it will. This patient, after 1 year, that suture get loose and pointed, and the patient presented like this. with the bad corneal ulcer at the wound side or at the suture place, and here you can see the hypopyon. So because of the comorbidity, we take also the sensitivity and the culture and trying to be gram-positive, but unfortunately it was gram-positive but resistant to the medication. It was only sensitive to ceftriaxone and penicillin G. Again, we are lucky enough to have these are prepared in our pharmacy. We started the medication. The issue and challenges in this patient is pseudophakic, and there is disruption of the descent membrane. They were talking about that you don't want to do AC washout, you don't want to give intracameral injection because you want to keep this barrier. This barrier is almost already damaged because of the previous surgery. So there is a close or open channel between the outside the eye and inside the eye. So the patient may go to endophthalmitis in no time. In that case, you need to be alert, and sometimes, especially when it is reaching to the sclera, sometimes we give oral antibiotics, and in this case also we give subconjunctival vancomycin and intrastromal vancomycin because of these two alarms. In the 11th day, and you need to be patient in following those patients. Here there was some deterioration. Definitely there was some deterioration here. There is some control here in the 7th day, 8th day, 9th day when we give the injection. After 11th day, we had some improvement. We documented improvement. So in that case, we reduce the medication, which has too much to be tolerated by the eye. We added the ointment because there was a significant melting at the area of infection. And in the 13th day, we started Brovera before the Bradford, and here is the 14th day picture. You can see out of this picture when you see here is the infiltrates become more whitish, the hypopyon started to disappear, and there is good control of the infection. You can see the patient after 4 months, a complete resolution of the infection. We saved the eye. Yes, it takes for a while until we get the right medication, but we control it well at the end, and the patient regained good visual acuity after that. Again, if you want to apply the same principle, this is mostly an infectious stage. We struggle here at this stage, but we didn't lose the temper. And after 2 weeks of struggling with antibiotics, we started here the inflammation, anti-inflammatory, and here we end up with a good healing. Without amniotic membrane, without tarsorrhaphy, the healing followed, even if in that patient with comorbidity. A third case will be a quick one. This is a patient, again, emphasizing the importance of don't leave suture in the either a post-BKB or post-phaco. This patient had BKB more than 1.5 years. The suture get loose and broken, get to the infection. The ER team removed the suture and gave the patient Sifta, which is a reasonable choice. Maybe it will not be the best, but they gave the patient the medication. Patient at this stage, they gave the Sifta, and here the patient came after 2 days. You can see the infiltrate is increasing. And here we question the patient compliance, and we question our medication. So we don't want to take any chance in BKB patient. We admit the patient at this stage, and we shift him to Vanco and Sifta, and the patient have good response. After controlling of the infection, we added the steroid, and the outcome happened like this. Sometimes you will be more unfortunate, and the patient will be unfortunate that you present with bad organism or late presentation. This is a lady who's diabetic. Because of problem with the eligibility in multiple places, she went to multiple ER until she landed in our emergency, and she is relatively immunocompromised. She came with a bad abscess, was resistant to first initiation of the medication. When we started the vancomycin and ceftazidime, we have good control. You can see the whitening here, the control of the infection, and when we started the steroid, the patient improved, and we can get good outcome for this. The patient still under active treatment. We saw her maybe for 2 days. Another case, maybe this will be the last one. This is a 10 years old patient who had VKC and early keratoconus. We were forced to do a cross-linking for this patient. So we did cross-linking, and after 2 or 3 months, he presented to the ER with this bad infiltrate. Patient was started in right treatment, but there was no much of improvement. Yes, there is control, but that stays for a couple of days, no improvement. We thought out, now it is mostly an inflammation rather than infection. So starting the steroid, and the patient improve. So as we said, if you target the right stage with the right treatment, you will end up having a good outcome. So in conclusion, microbial keratitis is a serious ocular disease that need effort to have a good outcome. Having a roadmap in managing such patients is crucial. Adopting a clear guidelines with the help will help both patient and treating physician not to get lost and to have a good outcome. And thank you.
Thank you, Dr. AlFawaz, for excellent discussion on the subject of microbial keratitis. As you know, there are many points that you have just mentioned. I have 2 questions. First, what was the organism in case 1 and case 2?
Which one? Just to remember.
Case 1.
It was Pseudomonas. Pseudomonas aeruginosa. The one responded to ceftazidime. It was Pseudomonas.
Yes, Pseudomonas.
Yes, it was a Pseudomonas.
And the second one, case 2?
It was a gram-positive. I'm not sure. Maybe it was strep pneumonia. I'm not sure, but it was a gram-positive.
Okay.
It was a gram-positive.
Because you put question marks about ceftazidime, and I agree that you can have resistant strains of Pseudomonas.
Yes.
But you have to keep in mind that there are certain antibiotics that we are very highly effective and we don't use.
Yes.
An example is polymyxin B. Is used only topical, and it is toxic to the kidney. You cannot give it orally or systemically. But polymyxin B. The second is ciprofloxacin.
Mm-hmm.
Ciprofloxacin is a good antimicrobial agent for Pseudomonas.
Exactly. Yes.
Because this is something you were mentioning about ceftazidime.
Yeah, Cipro, I think in the paper by Dr. Kalanta and the colleague, they found some resistant, but I agree. In fluoroquinolones, the first generation is, or the second generation is good in covering gram-negative. Yeah. But the other antibiotic, if you allow me to answer this, the problem that it's not available. And if you sometimes we are, as we discussed before this, the lecture,
it used to be called
handicapped.
Statrol, commercially by Alcon.
Yeah.
It used to be called Statrol. And there
Unfortunately,
is 15,000 international units of polymyxin B in it.
Yeah, here you see the gram Cipro was done, I think, in a couple of cases. It was
ciprofloxacin, 100%.
Yeah.
You see Cipro?
Yes, it was 100%.
Cipro is an excellent choice for Pseudomonas.
Yes.
And it should be used in these cases. But there is another point that I would like to mention that makes me unhappy when I hear it. We don't combine cephalosporins. And there is no such thing as combination of cephalosporins because they have the same receptor site. And if you use 2 cephalosporin, there could be competitive inhibition. So cefazolin plus ceftazidime is not a good choice because you think that cefazolin covers gram-positive, ceftazidime gram-negative, that's a good combination. No, because you can have competitive inhibition of this, and therefore, and as you have shown, when you combine them, the patient did not respond.
Yeah, but there are some cases that was respond. In fact, that point in specific, I was discussing with Dr. Khalid yesterday. I was telling Prof Tabara, he will comment on this. And I know you don't like usually using this. Now it is the rationale for me is clear. But still in literature, in books, it is combined. But we see it sometimes effective, but it won't be the first choice to be used.
your classification is excellent, and I think we should think about it more to make it more usable for for any ophthalmologist. And your judgment relies on the activity of the that is, if you see a yellowish infiltrates in the cornea, you will not start steroids.
Yes.
Yeah. So this is one thing which is excellent, and I think you should have experience in order to make the judgment that you are making.
Yeah, but there are some guidelines. But at the end, I agree that the experience is important to know. But there are some guidelines. But at the end, at the bottom, we don't want to have harm. And if you are questioning any of these stages, you can wait. Still, there is no harm to wait. There is no urgency to start the anti-inflammatory if you are questioning the infection.
The other thing is that as I pass by the emergency room here, they have a protocol for corneal ulcers. And I don't think it's a good protocol, because we should not follow protocols. We should do cultures and try to rely on the cytology. And not only once, but you may have to do it 2 times or 3 times, scraping the cornea, because sometimes you get patients on antimicrobials, and you have to use ARDs in these patients in order to get the antibiotic removed by the resins. So you will have to be careful when you start these so-called
protocols or guidelines. Yeah. The guidelines is important, but maybe it can be revised to fit the defects. But talking about the re-scraping or doing re-scraping, and this is another controversy I was expecting to have, because I don't know if Dr. Samar is around. We usually have some controversy between me and her. And do you stop antibiotics before doing re-scraping?
You see, if this patient is active, I don't keep him off anything. So I go ahead and do the scrapings.
And this is my rationale. I know there are some
sometimes I use ARDs. I tell if the microbiologist has ARDs.
I usually
sometimes
don't stop.
They don't have it.
If that is not effective and not causing any improvement, definitely it is not effective and will not affect our culture. But maybe if another colleague has opinion in this point of re-scraping. Dr. Saeed? Yes. Can give him Dr. Saeed at the back.
Dr. Abdurrahman.
I totally agree. I never, stop antibiotics before we do re-scraping, because I don't feel it is safe, as well as it doesn't change, I think, that much our result. The other comment that I want to mention now, Abdullah, it seems like a standard in your practice now, whenever you see a patient who is immune compromised or the bad ocular surface disease, or maybe with the sutures, that your standard treatment now is vancomycin and ceftazidime. Yes. Is it true?
Yes. Okay. But the other point I just want to mention, Prof, you mentioned it. Did you start 25 milligram per ml or 50 milligram per ml among the vancomycin? Again, in my practice, I found it.
50.
I found it toxic. If it is peripheral, it's not that bad infiltrate. I can start with 25, especially when you have a problem with the stem cells or the patient will need it for a long time. My practice is 25 milligram per ml is as efficient as 50. And maybe sometimes this will be in the tapering stage.
So yes. The question, is there still a room for 4th generation fluoroquinolone in such cases?
In practice, I usually do it when I want to discharge them on monotherapy.
No, I mean before.
In the tapering. Before
initial treatment.
Mostly I want, because in fact in the practice, mostly those patients are already on fluoroquinolone. When they come to the ER, they are already in fluoroquinolones. But again, if you have the sensitivity like Prof alluded to, the ciprofloxacin is a good option. Fluoroquinolones from the literatures, either Zymer or Vigamox is important medications, and it gives some good effect. But for my practice now, if it is severe, I will go immediately to 45. If it is peripheral, small one, I go with monotherapy.
Okay, because it's still, and I think I usually initiate with 4th generation fluoroquinolones in such cases, while with the close monitoring, to ensure that we can catch any progression or lack.
Without
usually
without
Vigamox,
45
is
without Prof, without as a replacement ولا with
without as my initial treatment. Okay.
Vigamox you are talking about?
Yes.
Moxifloxacin.
Uh.
The good thing about moxifloxacin, it does not have preservatives. It has 0 preservatives. And therefore you don't knock off the stem cells that Dr. Fawaz is mentioning. So this is a good point about moxifloxacin. Are there any questions?
لا دكتور سعيد I can't hear him.
Thank you very much, Prof. Abdullah, for a very informative and straightforward lecture in a very important topic which we are daily facing in the emergency room. Unfortunately, most of patients come to the hospital, either King Abdulaziz or King Khalid, already received many antibiotics and already having 1 week, 1 month with the different ophthalmologists, different treatment. So patients come with a different picture. It's not a straightforward picture as mentioned for in the lecture or whatever presentation given. So usually those patients it need, which I found it over the years, missing in most of the people, history is very important, and which will guide you how to approach your patient. This is number 1. So, and why I'm mentioning this, because we have with us residents, we have with us fellows, and it's important for all of us, not only that. So a history is very important, and it will direct you to the, and usually I divide my patient into 3 categories. Below 25, and I know those patients, what they are usually having, 25 to 50, and they have some diseases, and above 50, and they have. In the above 50, most of the patients, they have lid problem, rubbing lash, and which always rubbing the cornea and lead to another infection. And in the past, we have 10 folds of files, and it's the same. The problem is just only eyelash, just rubbing, get infection again, and these things. When you have these things classification and you know where is your patient is going, you can manage easily. It's just only to take scraping. And Prof. Tabara, Prof. Khalid, he mentioned protocol emergency room. Dr. Uthaymin and Dr. Amri, they are not here. I totally agree with them, which is very helpful for resident. And most of the time, all patients, they get scraping, they get everything, and they start the treatment. So the protocol is just only guideline and helping the physician in the emergency room and also for the anterior segment to have the proper pathway of treatment. So this is for the antibiotic. I found it's very, very important to have combination, and don't rush to just only take out or stop or decrease it till you make sure the patient is, and usually in the first week, this is the aim to find what's the cause, because most of the time it is dilemma. You have a negative outcome from the scraping, you have all these things. So this is, it's not just only easy as it's mentioned. No, sometimes you scrape once and twice and you don't find anything. Okay, so clinical finding is very important to guide you. This is one thing. Regarding steroid, I'm using it from first week, and it's very helpful. It will decrease inflammation, and it will minimize, make things better for the patient. And usually, I divide it into 3 stages. First stage, to find what's the cause, and make sure you find what's the cause. Second stage, to improve the situation and to improve the management. Third stage is to prevent complication. And this is to, sometimes you manage the infection, but you still with scarring and all these things. And so as you exactly mentioned, these stages is very important. And I think this is was covered very well. Thank you very much for that.
Thank you.
Good points. Thank you. There is one point about the mass use of steroids. They should be very selective in these cases. Dr. Fawaz outlined a very good way. I don't think we should tell our residents to go ahead and use steroids on all patients. Nocardia, for instance, it's a contraindication to use topical steroids. And we don't use it. So you might be selective and follow the guidelines that Dr. Fawaz mentioned. And
Yeah.
yeah.
Right.
And this is what
Yeah.
we are doing
Yeah.
over
Sorry.
the years.
No, and
The treatment should be cytology driven and should not be blindfolded and give protocols. Okay? So I agree with you about the points that you mentioned, but about some of the organisms that might do very bad with the steroids because you knock off all their immunity. You said about the combination. Dr. Fawaz mentioned that combination may be used in certain cases. I just want to tell you that if you have acanthamoeba, you cannot use single antimicrobial. This is an animal. It's a one-celled animal. And you cannot use only one antibiotics for it. You have to use 4 in order to kill the acanthamoeba, to get rid of it. So this is the thing, one thing. Another point that I would like to mention, if you allow me, Dr. Fawaz,
Prof.
is the type that I classify organism. I call them indolent versus fulminant. Fulminant, it's another issue. I should find out the cause immediately. I stay with the patient. I don't let them go until we find the organism. While if you look at the indolent, there are organisms that I have seen not responding to antimicrobial because they are not given the proper antimicrobial. And examples are Mycobacterium, for instance, atypical mycobacteria, Mycobacterium cheiloni, Mycobacterium abscessus, Mycobacterium and other types of mycobacteria. These do not respond except to multiple antibiotics. You have to combine some antibiotics and you cannot use a single antibiotics. So the indolent causes of corneal ulcers are fungi, acanthamoeba, and mycobacteria. These are some, and nocardia. These organisms do not respond to all your antibiotics that are on the market, not even the one that you make in the emergency room. So I think one has to make sure that we are not missing the organism and to give the appropriate antibiotics so that we will prevent the complications later on.
Yes, I agree totally. What mentioned by Dr. Said is very important. And talking about these, a few examples that we have patients that we started in our eyes with a steroid, and the second day there is progression or worsening. And when you stop it and they take another scraping, it tend to be a acanthamoeba. And the patient that I showed to you, there was some patient who was started on steroid, they get improved for a while, and then when you stop it, they will be flaring. And these are cases that you need to be cautious. But I agree with the other two.
Our problem here is not treating it. Our problem is that the availability of antimicrobials. We don't have antibiotics. There are so many eye drops that are not available on the market.
Well, this is one of the logistics. The logistic problems that we don't have. This is why you need to look to the literature, refresh your for preparing medications in the pharmacy, getting some other medications that can help. But at the end, unfortunately, because you are talking about the moxifloxacin, the other moxifloxacin that prepared or manufactured here has some preservative, and it's not as effective as Vigamox that we are using. Arox.
Has preservatives.
It is not as effective as Vigamox. Again, you need to go back to what you are preparing, and still my golden standard is the fortified antibiotics. There is one question in the back.
Thank you, Prof. Abdullah, for your interesting presentation. I want to ask about the fungal keratitis. I'm not aware if natamycin is still available in the market. Currently, I think it's difficult to get natamycin. So usually, would you start from the beginning, 2 medication, amphotericin and fluconazole, And at what stage you would start systemic voriconazole? For all the patient or for selected cases?
My quick answer to this, I usually start with whatever available. I give voriconazole, I give amphotericin B, and give fluconazole orally. I don't have time to. This is one of the indolent I was saying, Prof. And the response will take time, and unfortunately, the progression will be toward the area that you don't like. They will go to the sclera. And as far as they are in the cornea, you have a good chance that they will be controlled with these medications. Even voriconazole is a good medication. It was a rescue for us when the natamycin was not available. Voriconazole, in terms of fungal keratitis, for the last couple of years or 15 years now, voriconazole, the ophthalmic preparation of voriconazole and intrastromal is good. And you can do it multiple times.
Exactly. This is a very good approach, and it assures the high levels pharmacokinetics in the cornea. Otherwise, you don't have enough from the drops that you put. You have to give it intrastromal, and this is a good approach and a good strategy for the treatment of fungal keratitis. Unfortunately, we don't have natamycin. We don't have any eye drops or ointment for fungi on the market.
The problem يعني هذا محتاج
and
discussion
the Ministry
طويل.
of Health prevents you from doing it unless you go to emergency room of King Abdulaziz or to KKH.
No, the natamycin, Prof, is even not available, and أعتقد أن الجمعية السعودية or maybe KKH, they're trying so many times with Saudi FDA to get it approved. There is a funny story I can tell you. Mohammed Abu Saif is not around. Mohammed Abu Saif was in Singapore, and they were getting the medication natamycin by almost 20 riyals البطل from Bangladesh. It was prepared there in a well standard company, but ما عندهم فسح للسعودية. ناتامايسن اللي موجود الاوريجينال 1 في UK تقريبا 3000 ريال one bottle. Both of them are prevented to go in, يعني not available, and we try to get special فسح. يمكن يعرف الدكتور صالح من السعودي كوميشن من الهيئة هذه وردوه في الجمارك. The one in Bangladesh, Muhammad, this is a funny one. We ask the company to send for us a sample. We will donate for you a big box of drops, and they send it to Jamarik al-Riyadh, and they reject it back. Well, unfortunately, our patient ended up doing BKB and. But I think whoever, Madam, now we are discussing this in open discussion. If anybody has any link to the Saudi FDA, by any way, you need to. This is a serious issue. You need to have medication.
I have been a member of the committee for 5 years for the instruments, but I know nothing about the drugs, what goes on in the other committee. I told them about it, and they said they cannot do anything about that.
We can arrange. Maybe I'll talk to you with Dr. Al-Jabari.
Yeah.
We are in deep problems, and we are not treating our patients properly because of the logistics.
I have 3 questions for you, Dr. Prof. Tabar, Prof. Fawaz, and the audience. Now, do you ever use vancomycin at a rate of Q1 hour for a week
it's
or more?
very toxic. It's really
because I have seen a lot of patients, and the dilemma was, sometimes you see a patient and you'll be informed that patient is not responding, and when you see them, they are using vancomycin every 1 hour for a week or 10 days now, and most of it is toxicity rather than just a progression of the infection. So what will be the rationale for using high frequency of vancomycin from the practice?
You can use it intrastromally. Injection is very easy.
And if you use it topical, you will use it every 1 hour for how long? 2 or 3 days or more or less?
You cannot use it for 3 days. The patient will come back to you.
Toxic.
Very toxic, very irritating.
I usually use it for a couple of days, 1 week or 10 days. As far as there is active infection, and this is why I'm saying to you, the inflammation is still an issue. When toxicity is still an issue. But if there is good response, then unfortunately the Staph aureus resistant to other medication. And if you lose timber or you taper this prematurely, you will end up with having a problem. This is why I usually started most of the time 1 week to 10 days until if I think there is still need of Q1 hour or Q2 hours medication. And this is why I'm saying, I asked you a while ago about the 50 and 25. A shift from 50 to 25. But still, it is toxic. يعني, gentamicin is another one which is toxic. Well, which is good coverage, but it is toxic.
Because the other suggestion that some people follow different guidelines that when they initiate with every 1 hour, then they go from every hour to QID after
Immediately.
third day. And
Yeah.
it's not amount of tapering because they just want to load a patient with the right antibiotics.
This should be according to the response of the patients, not per hour,
Okay.
but per response of patients.
A second question, you discharge this case, there's a case here that you discharge him with the epithelial defect. So you feel safe, and because I see a lot of people now, what they follow now, they keep patient until full epithelium healing achieved. Yeah.
Yeah. No, that patient mostly was discharged with complete healing.
Complete healing.
Complete
Yes,
healing.
now, the problem now for people who are going to practice either in private or in a hospital where they don't have access for antibiotics, we don't want to tell them now, send any corneal ulcer to tertiary care, because still I think they care. So do we want to send this message now? Every corneal ulcer should be managed in a tertiary care eye center
Until we get the antibiotics.
until we get antibiotics.
No, I think the general rule, the guide message from our president, one is not to harm. If you don't have the right medication, refer them. If you have the medication, which is mostly available, 4th generation fluoroquinolone is the reasonable antibiotics. But don't start steroid empirically, and don't start combination treatment empirically. All these need to be prohibited.
If you develop a fungal keratitis in Saudi Arabia and you want treatment, there is no treatment. I'm sorry. You have to go to a governmental hospital in order to get treatment, if there is treatment. If you have to go to Dr. Fawaz to get the treatment. But unfortunately, we don't have antifungal agents. No drops, no ointments, nothing. And tell the Saudi FDA.
Dr. Omar.
Thank you very much for this nice lecture. As important as the medications also is having good diagnostic tools. Most of the time scraping is done in ER, and it's done by the least experienced member of the managing team. So re-scraping, that's why sometimes re-scraping, you get a yield in the second re-scraping, while you don't get anything in the first one. A good lab, if you know what you are treating, then you can, for example, say, okay, this organism is so and so, I have to insist on using this sort of medication. If you lack a lab that supports you, then what you are doing is just in vain. Most of the corneal infiltrates are creamy, so there are some differences, but you cannot be 100% sure just by looking at the infiltrate in many situations. That's why you need the lab. The other point is, even at KKH, sometimes we have deficiencies in some very important medications. Let's say that you admit a patient and you don't have the necessary medication. What will you do to the patient? Will you tell the patient, I'm sorry, I cannot treat you?
Send them to Germany.
Yes, I think because
if
keeping the patients,
if he can afford.
it's not the building that treats the patient, it's the medications. So if you don't have the medications, I would rather tell the patient, I don't have the medication, I'm sorry.
The problem with
Good
Kramer is not, the answer is not usually like this. You have less efficient medication. Will no medication at all?
No, I mean, if there are other medications available in other places, let's say in town.
There is no Proline.
Let's say that the medication is available somewhere in the town, but not in your institute.
Yeah. Again, definitely you will ask for it. يعني we have
available in town.
Proline?
I'm talking in general. Sometimes it's not available.
Proline is found in the in UK in every pharmacy.
Neomycin again also in there is not available.
They have antibiotic ointments. Do you have erythromycin ointment here? No.
We have something that does
you
not
have
work.
in KKS.
Only in hospitals.
We're talking about.
We have erythromycin, but most of the
Private
patients
sector.
complain. They don't like it, and it burns, and it hardly works.
لا هو طبعا definitely دكتور أبو أسامة دكتور عمر if you don't have it definitely you send the patient but you try to give the patient the best يعني the natamycin that we are talking we ask somebody going to the UK to bring it for us وهذا محمد we try to bring it we try until struggling to give the patient as much as we can and hopefully this will be temporary things and it will be corrected دكتور صالح يمكن last comment أن طولنا على
We have plenty of Bangladeshi workers. I think we now are talking about the lack of certain medication to treat critical situation of corneal ulcer. I think there's such thing as Dr. Abdurrahman mentioned that we could speak to Dr. Al-Judai and ask him about this medication that is needed, highly needed by ophthalmic field.
It's very good.
And we could identify the local dealers who could. I didn't think the volume was very high. Let's say that for natamycin. I mean, I didn't think we'll have 1,000 fungal keratitis per year. I didn't think this is a high. I don't know how many cases we think we have per year.
I don't think it's a large number, but usually you call a number in the States, for instance. You call a number and you order it by mail.
I think this is the way that if.
Well, this is the problem with that of the medication that we mentioned to the Saudi FDA that the company will not buy to go to all these logistics for a profit of a marginal profit of few thousand. هم الاشتراطات الآن تلزمهم إنهم يدفعون وبروسيس وفيز ومعقب.
The license.
وفي الأخير you need 100 bottle.
The license to give a license for one medication sometimes 35, 40,000 just to give the license.
Yeah, this is why. This is why erythromycin is very cheap medication, not available.
But I think Dr. Saleh, you and Dr. Abdurrahman and who are in the circle, you can find out solutions for or you can form a committee to define what's not available and then try to find solution for it.
This is, if you look at, this is just for medication. Sometimes we have difficulty to get the brachytherapy for malignant intraocular tumors. We didn't have easy access to get it. But this is, I mean, there is a certain limitation in the medical field. I didn't think it's only just limited to ophthalmic field. Even maybe other specialty have the same problem.
Yeah.
Before we conclude, I would like to thank you once again, Dr. AlFawaz, for an excellent presentation, and we all learned from it. I also would like to give an addendum to what Dr. mentioned, and this is regarding the use of steroids. I don't use FML as it is marketed. In most cases, when I need FML, I put 2.5 cc's of BSS in it. I make it diluted. So I think you don't need the whole FML, and you can use a diluted form of FML for the inflammatory phase of the disease.
Why you are mixing it with?
Not to have a high dose of FML.
Okay. And mostly the good thing about FML, yes, maybe it is potent, but the penetration of it is low. It will not give usually.
It is for
the pharmacokinetic itself is preventing.
Yeah, you are right.
Yeah.
Thank you very much, Dr. Abdullah, for the great lecture. I'm interested to hear your strategy on steroid lecampaniba.
Yes.
Do you use it and how do you use it?
Yeah. Mostly in general, we don't use it. And there is some reported case and reported strategies. If you have stagnated response, let's say after 6-8 weeks, there is no disappear of the, there is a rationale saying challenging the organism by starting some steroids, so the acanthamoeba cyst will go to the trophozoite and then you will hit it. This is a strategy that can be used, but in general, we don't use steroid anti-inflammatory, whereas active acanthamoeba is there. This is the general message.
One question, why we don't have Proline here? Why do you have to go to London to get Proline?
Again, it is licensing.
Licensing.
Licensing. Neomycin, Proline, Erythromycin, the company they are not willing to take the license. فكان يجي بفسح عن طريق الصيدليات لما كانت الأنظمة.
هذه يا
I
عبدالله.
overcome one lecture, one paper from Moorfield, if I remember correctly, that they said Proline, the only benefit in acanthamoeba is the benzyl chloride material in it. Do you find it very effective?
No.
I'm not sure.
I told you, these are single cell animals, and you have to use 3 or 4 antimicrobial in order to kill it. It's not enough to have Proline.
Yeah.
You have to use the other chlorhexidine, and you have to use the other 2 that.
Antifungal.
Yeah.
طيب. يعطيكم العافية.
Thank you very much. Thank you.